I'm going to talk to you about the optic disc in myopia. The optic disc in myopia shows a variety of features. Can you switch this on? Yeah. High myopes are thought to have large discs, and myopic discs are thought to be more predisposed to glaucoma. In fact, Professor Yost, who's done a lot of work on the optic disc, often used to say in his talks that every myopic disc should be considered to be glaucomatous unless proved otherwise. I think clinically that is good fundamental, so that when we're looking at the myopic disc, we think about the fact whether this patient has glaucoma or not. High myopes are thought to have large discs, and myopic discs are thought to be more predisposed to glaucoma, and that's already been proved statistically that if you have patients that are more than -3 diopters myopic, then the possibility of their having, that is the prevalence as well as the incidence of glaucoma, goes up compared to those who have less than -3 myopia, or those who have hypermetropia of, let's say, up to +2 or +3 actually. That means that if you're an emetrope, you may have less chance of developing glaucoma than if you were to be a myope actually. Appearance of the myopic disc, the rim and cup differs from emetropes, and I'm going to take you through several photographs of the myopic disc actually. Let's take a look at some examples of clinical implications of the optic disc. The optic disc size was found to be 2.25 square millimeters. The optic disc size was found to be 2.25 square millimeters, and the range was 1.12 to 4.61 millimeters that I mentioned to you in my previous talk this morning. And so we have a definition of 1.3 millimeters square as small discs and 3.27 millimeters square as large discs, and that is based on the mean +2 standard deviation. In the Central India Eye and Medical Study, the disc size was found to be influenced significantly with myopic refractive error and with axial length, and that's important actually. The clinical importance of optic disc size is known from the fact that large discs have large cups and may be suspected to have glaucoma, and small discs have small cups and may be missed to have glaucoma. However, the question that arose from our clinic-based study was, could optic discs in myopia be small? Because they were looking small, and we measured them. We found on looking at a series of subjects in the clinic with high myopia of more than -8 diopters that high myopes may have small discs actually. -8 diopter is taken as a cutoff, so everything above -8 diopters is considered to be high myopia, and everything less than -8 diopters is considered to be moderate myopia. In a sense, while high myopes may have large discs, they may also have small discs, and that's important for us to understand. This is important because all myopes should be specifically clinically assessed for glaucoma, and we know that if you have a small disc, it's already difficult to diagnose glaucoma, and if you have a myope who's more predisposed to have glaucoma and he has small discs, then it's going to be even more difficult to diagnose glaucoma, and we should not therefore miss that actually. So there is a chance to miss glaucoma not only in large discs in myopia, because large discs are difficult to assess, and I will show you some photographs, but there's a possibility of missing out glaucoma because some of these patients have small discs actually. So these are photographs of small discs and large discs. This is a small disc that you're getting in myopia with a large area of parapapillary atrophy. I think the distinction between parapapillary and atrophy and beta zone, the classical beta zone, I will make in the next slide. So this is what you get, and the disc area here is just 1.41 millimeters square actually. The disc area here is 2.8 actually. So that's a small disc in myopia, and this is a large disc in myopia actually. It's not as large to be classified according to what I just told you, that it should be more than 3.27 millimeters square, but this is a larger size disc, and this is a very small disc. So we need to understand, and of course there are many reasons why this happens, and a recent paper that's come out of San Diego might explain why we get some of these discs to be smaller in myopia actually. We studied the shape of the optic disc. The normal optic disc shape is described as being vertically oval. In our study of 147 eyes with a mean refractive error of -6.4 plus -2.98, we found that there was little difference in the axis measured at 30-degree intervals actually. And in general, the optic disc was found to be vertically oval in the majority of subjects, that is at each 30 degrees we measured the axis actually, and we found that this axis, this vertical axis, was a little bit larger, and that large axis was found in 50% of the patients. So I think that needs to be held true actually, that the disc is vertically oval. The beta zone is considered to be associated with glaucoma and its progression. Many non-glaucomatous myopic discs are associated with parapapillary atrophy, and we need to distinguish what is parapapillary. Parapapillary atrophy could be a generalized term, so that any atrophy that you see around the optic disc could be classified as parapapillary atrophy. But there's a beta zone that you find that's classically described in glaucoma patients and also found sometimes in normal patients. And then you get a classical beta zone in a myopic patient, and then you get a classical parapapillary atrophy that's different histologically from the beta zone that you get in glaucoma patients actually. Many non-glaucomatous myopic discs are associated with parapapillary atrophy. This raises the question whether the pathogenesis of this atrophy is different from that seen in normal eyes, or if it may have a bearing on the future development of glaucoma and myopia. So we're talking of two different kinds of parapapillary atrophy, and we're trying to figure out whether either of these have got a role to play in the development of myopia. So this is a beta zone that you find. This is a classical beta zone actually. -6 diopter myopia, disc area is 2 millimeters, and 1.92 millimeters in the right and the left eye actually. So you can see this classical beta. So this is what we call as the classical beta zone actually. And this is asymmetry of parapapillary atrophy actually. So this is the classical beta zone. The right eye is -7 diopters, and this is, some might call it the beta zone, some might call it parapapillary atrophy. This patient has -20 diopters in the left eye versus -7 in the right eye. And that's the asymmetry that you can get not only in the shape of the disc, but also in the color of the optic disc, and also in the parapapillary atrophy. So this is a patient who has a refractive error of about -11 diopters. Disc area is about 3, and she has -9 diopters, and disc area is about 2.14. And you can see the parapapillary atrophy and the different characteristics of parapapillary atrophy. It's very hard. When you have parapapillary atrophy, there is increased disc pallor, that you can see that here. And when the disc is large and you have such parapapillary atrophy and there is so much pallor, it becomes exceedingly difficult to diagnose glaucoma, because it's not easy to determine where the cup begins and where the rim ends. It's really hard to identify the junction actually, whereas it is much more easier in this optic disc actually. So this is the beta zone in myopia. Normally, this is what we call, which might be called parapapillary atrophy or beta zone. And so when we did a scan passing to the optic disc, this is where the parapapillary atrophy is actually here actually. So if you did a normal beta zone spectralis scan, then this Brooks epithelial junction would extend right up to the margin of the optic disc. In fact, it's the margin of the neural canal, and it defines the margin of the optic disc. But when you do it in such a patient, then you find that the Brooks is actually ending here at the edge actually. And therefore, using the OCT with a line scan across the optic disc may perhaps be the best method of determining whether this is the parapapillary atrophy typically described and associated with high myopia, or whether this is beta zone that we often suspect may be associated with glaucoma. And this is the beta zone in glaucoma. You can see the beta zone, and you can see that the Brooks membrane is ending right up here actually. This is the retinal pigment epithelium here that is ending here, and this correlates with the beta zone margin, and this correlates with the optic disc margin, which we have already proved on histology actually. The retinal nerve fiber layer was found to correlate. We had a large group of myopic patients, and we studied the retinal nerve fiber layer using the Heidelberg retina tomograph. And the retinal nerve fiber layer the mean retinal nerve fiber layer was 0.22 millimeters actually. It correlated with the spherical equivalent, that is, lesser the myopia, the greater the thickness of the retinal nerve fiber layer. And you can see that clinically, that when you have low myopic patients, you can see the retinal nerve fiber layer much better actually. It correlated with the axial length actually. That is, if the axial length increased, the retinal nerve fiber layer thickness decreased. It was associated negatively with the cup area. It was associated negatively with the cup disc area ratio. It was associated positively with the rim disc area ratio actually. It was associated positively also with the rim volume. But what was most surprising was, I'll continue for a minute or two because I missed out on the previous talk actually. But what was most important was that we did not find a correlation of the retinal nerve fiber layer in myopes with rim area. I think it's too premature for us to say anything at this stage. But I think it's just important for us because it could simply be because the reference plane is not working in myopic patients or it's not accurate or whatever actually. Because for long we have understood that if you have a larger rim area, and that's all we have been able to measure on the optic disc photographs, then you had a thicker retinal nerve fiber layer, and those correlations are well established in the literature actually. So this is the clinical shape of the optic disc. The shape of the optic disc differs. You get a variety of shapes that you can actually classify. And this shape is somewhat obliquely oval actually. And then you have these oblong discs actually. That is, they are long, they're vertically much longer than these oval discs actually. So this is what we call as the oblong disc actually. So you get a normal disc that you get in normal patients, you get a horizontally oval disc, you get discs that are obliquely oval, and you get oblong discs, and of course you also get tilted discs. And this is a micro tilted discs. Because it's just 1.1 millimeter in the right eye and 0.8 millimeter square in the left eye actually. And these of course have their own difficulty when we're trying to diagnose glaucoma. And this is a lady who's high myope, whose discs are 2.03 and 2.86 millimeters in the left eye. And this is the right eye, by the way, and this is the left eye actually. You can see in tilted discs often hard to make out actually because of the origin of the blood vessels. And this disc is very significantly myopic, and this disc is also myopic. And because the disc is tilted and this area comes inferiorly, and there is a slope. In fact, you can't get a proper reference plane with the Heidelberg retina tomography. So there's already a slope that makes it difficult in tilted disc to diagnose glaucoma. And also we know that there is increased tessellation, and sometimes you might find a greater degree of visual field loss even in normal patients with tilted disc, which has been well demonstrated. And also because the retinal nerve fiber layer readings, even on the OCT, as Shushmita will tell you, don't come out accurately. Therefore it becomes extremely difficult to diagnose these patients whether they have glaucoma or not, and therefore these patients deserve some special attention and time. This is optic disc pallor actually. This is a patient, this is a high myope actually, and the optic discs are pale actually. And you can get that actually. Pallor in optic disc, pallor of the optic disc in high myopia is a known clinical entity that you will recognize when you see your patients actually. Fundus Tesselation is another association of high myopia. This is a -8 and -9. You can see the degree of fundus tessellation. And the greater the degree of fundus tessellation, or greater the degree of parapapillary atrophy, the greater the degree of optic disc pallor. And you can make out the difference between the right eye and the left eye, where the degree of tessellation is a little less, but the disc is a little more pink actually. The optic disc in myopia is a collection of a diverse array of what is considered normal for myopia and abnormal otherwise. It offers a direct challenge in the interpretation of its myriad signs. Diagnosing glaucoma and treating glaucoma will continue to be a challenge in myopic patients actually. And clinical skills may sometimes be very, very important. Thank you very much.